Hello guys, welcome to our new session. In this session, we are going to discuss about adrenergic agonists. What are adrenergic agonists? Adrenergic agonist is a drug that stimulates a positive response from the adrenergic receptors. Before going into deep, we need to know about two main structures. They are beta-phenylethylamine, which is a basic compound for sympathomimetic amines. And you should know about catechol nuclease, which is a basic nucleus of catecholamines. Catechol nucleus has two OH groups, 1, 2 hydroxybenzene is called as catechol. Then what are catecholamines? A catecholamine is a monoamine neurotransmitter that has catechol and a side chain amine. So the examples of catecholamines are dopamine, noradrenaline and adrenaline. So here you need to know prior going into the subject that noradrenaline is also called as norepinephrine and adrenaline is also called as epinephrine. Coming to noradrenaline, noradrenaline is released from synapse whereas adrenaline is released from adrenal medulla. The catecholamines are again divided into two types, endogenous and synthetic. Endogenous catecholamines are produced within the body, for example adrenaline, noradrenaline and dopamine, whereas synthetic catecholamines are synthesized, which are isoprenaline, dobutamine, dopexamine and phenyldopa. Adrenergic neurotransmission. So in this adrenergic neurotransmission, we are going to discuss about the synthesis, uptake and neurotransmission of noradrenaline and adrenaline. The enzyme tyrosine is synthesized in the liver and it is taken up by adrenergic nerve terminals. In the adrenergic nerve terminals, in the presence of enzyme tyrosine hydroxylase, tyrosine is converted into DOPA. DOPA is converted into dopamine in the presence of an enzyme DOPA decarboxylase. This dopamine enters into the vesicles. In the vesicles, dopamine is further converted into noradrenaline in the presence of dopamine beta hydroxylase. When there is an action potential, there is a large influx of calcium ions into the neuron and the vesicles fuse with the membrane and causes a release of noradrenaline. The released noradrenaline enters the adrenal medulla. In the adrenal medulla, in the presence of an enzyme N-methyltransferase, noradrenaline is converted into adrenaline. So there are various drugs which act in this mechanism. These are the tyrosine hydroxylase is inhibited by the enzyme alpha-methyltyrosine, whereas DOPA decarboxylase is inhibited by carbidopa. The entry of dopamine into the vesicles is inhibited by reserpine. The dopamine is entered into the vesicles with the help of an amine transporter, and the release of noradrenaline is inhibited by guanethidine. Dopamine beta hydroxylase enzyme is inhibited by copper chelating agent or disulfiram. So as you can see here, DOPA decarboxylase enzyme is responsible conversion of DOPA to dopamine, but decarboxylase enzyme is not specific to DOPA but also acts on other similar substances. Coming to the example, alpha-methyldopamine in the presence of decarboxylase is converted into alpha-methylnoradrenaline. Alpha-methylnoradrenaline acts as a false neurotransmitter. Now the synthesis is completed. Coming to the uptake of noradrenaline, noradrenaline is mainly uptaken by two mechanisms. The first one is uptake 1 mechanism, which is supported by sodium chloride dependent norepinephrine transporter, in short NET. The uptake 2 is extraneuronal amine transporter, which is also called as ENT. It is present in glial cells, hepatic cells and myocardial cells. The uptake 1 is inhibited by tricyclic antidepressants by like imipramine or serotonin noradrenaline reuptake inhibitors by duloxetine. The uptake 2 is inhibited by corticosteroid. Now we have completed discussion about synthesis and uptake of noradrenaline. Coming to the metabolism, there are two main enzymes which are helpful in the metabolism of noradrenaline and adrenaline. They are catechol O-methyl transferase, which is called as COMT in short, and monoamine oxidase, which is called as MAVO in short. So noradrenaline and adrenaline in the presence of catechol O-methyl transferase forms normetanephrine and metanephrine respectively. Noradrenaline and adrenaline in the presence of MAVO gives rise to dihydroxymandelic acid. Dihydroxymandelic acid, normetanephrine and metanephrine in the presence of COMT and MAVO respectively gives rise to vinyl mandelic acid. The final metabolite forming in this metabolism is vinyl mandelic acid. So we can clearly consider vinyl mandelic acid as the major metabolite and dihydroxymandelic acid is the minor metabolite of noradrenaline. Coming to the receptors. Basically, the adrenergic system contains of two types of receptors. They are alpha and beta receptors. Alpha receptors are subdivided into alpha 1 and alpha 2, and beta receptors are subdivided into beta 1, beta 2, beta 3. For now, you remember these alpha and beta receptors are subtypes of G protein coupled receptors. Beta receptors are subtype of GS type of G protein coupled receptors, which increases cyclic AMP. Alpha 2 are belonging to the GI type of G protein coupled receptors, which decreases cyclic AMP. Alpha 1 receptors belong to GQ type, which runs through a pathway of IP3 and DAG. So, coming to alpha receptors are always excitatory except in intestines. Beta receptors are always inhibitory except in heart. So, coming to the specific receptors, alpha 1 receptors act on the smooth muscle, causes contraction except for gastrointestinal muscles. Alpha 2 receptors are present in presynaptic nerve terminals. When stimulated, cause decrease in noradrenaline release. Alpha 2 receptors are also called as autoregulatory receptors. Beta 1 receptors are present in heart and when stimulated cause increase in force of contraction. Beta 2 receptors are present in smooth muscles, causes relaxation. Beta 3 receptors are of less significance, but their presence is situated in adipose tissue which causes lipolysis. The clear description of each and every receptor and their location and function is described here. As you can see, alpha 1 receptors is present in smooth muscles. Vascular smooth muscles, it causes contraction, whereas alpha 2 receptors present in vascular smooth muscles also causes contraction. Beta 2 receptors present in vascular smooth muscles causes relaxation. While coming to non-vascular genitourean muscles, alpha 1 receptors causes contraction, whereas beta 2 receptors causes relaxation. Gastrointestinal muscles, all alpha 1, alpha 2, beta 1 and beta 2 receptors causes relaxation. This is the only area where all the receptors causes same action. Coming to the bronchial smooth muscles, beta 2 receptors causes relaxation, inhibition and autocoid release. So from this, you can clearly make out that in GI smooth muscles, all types of alpha and beta receptors are present, and in bronchial smooth muscles, beta 2 type of receptors are present. Coming to the liver, there is presence of alpha 1 and beta 2 receptors. When alpha 1 receptors are activated, it causes glycogenolysis, and when beta 2 receptors are activated, it causes glycogenolysis and gluconeogenesis. In heart, alpha 1 receptors increases the force of contraction, whereas beta 1 receptors causes increases force of contraction. So the both alpha 1 and beta 1 has similar action in heart. In the eye, alpha 1 receptors when activated cause mydriasis. Posterior pituitary, beta 1 receptors causes release of antidiuretic hormone. In blood vessels, alpha 1 receptors causes contraction, whereas beta 2 receptors cause dilation, which leads to fall in blood pressure in arterioles. Beta cells of islets of Langerhans. The presence of alpha 2 receptors will cause decrease in the insulin secretion, and the presence of beta 2 receptors will cause augment insulin. But when compared to beta 2 activity, alpha 2 activity is the major thing. Coming to the uterus, When alpha 1 receptors are stimulated, it causes contraction. But when beta 2 receptors are stimulated, it causes relaxation. Coming to the vast difference, when alpha 1 receptors are stimulated, it causes contraction. In skin, alpha 1 receptors activated, the sweat glands increases sweating, and in the pilomotor muscle, there is an increase in piloerection. Coming to the urinary bladder, sphincter and trigone are contracted. Coming to trigone, trigone is a triangular region in urinary bladder which, when stretched, sends signals to the brain to empty the bladder. And detrusor muscles are relaxed when beta 2 receptors are activated. What are detrusor muscles? Detrusor muscles are relaxed when relaxed causes storage of the urine, and when contracted causes release of the urine. In the kidneys, alpha 1 receptors inhibit the renin release, and alpha 2 receptors will increase the renin release. In the platelets, alpha 2 receptors will cause platelet aggregation. Coming to the drugs, the classification of drugs. The drugs are classified into direct acting, indirect acting, and mixed acting. Coming to the direct acting drugs, there are non-selective and selective. Coming to the non-selective drugs, the first drug we are going to discuss about is adrenaline. Adrenergic shows its action on alpha 1, alpha 2, beta 1, beta 2, and beta 3 receptors. In the sense, it shows action on all the receptors. So, when adrenaline is administered, what are the various reactions occurring in the body? When coming to the eye, adrenaline causes decrease in intraocular tension, mydriasis. Adrenaline is not topically used because due to poor corneal penetration. Coming to the heart, when adrenaline is administered, it shows positive inotropic, positive chronotropic, and positive dromotropic effect. What is positive inotropic effect? Increase in the strength of contraction of the heart muscle is called as positive inotropic effect. What is positive dromotropic effect? Positive dromotropic effect is the increase in the conduction speed in the AV node, and positive chronotropic effect is the increase in the heart rate. Coming to the blood pressure, when the low dose of adrenaline is administered, it is more sensitive to beta 2 receptors, so it causes decrease in blood pressure. But when high dose of adrenaline is administered, first it causes increase in the blood pressure due to effect on alpha 1 receptors, which is predominant, and then it will cause decrease in the blood pressure due to its effect on beta 2 receptors. What is Dale's vasomotor reversal and how it is different from biphasic response? Dale's vasomotor reversal, when a patient is first administered with an alpha receptor blocking agent, and then the patient is administered with adrenaline. The alpha 1 receptors are already preoccupied with alpha blocker, so the beta 2 effect is only seen on beta 2 receptors. So instead of rise in BP, you will see a fall in blood pressure. Coming to vascular smooth muscles, the alpha 1 receptors causes constriction, beta 2 receptor causes dilation, and alpha 2 receptors causes constriction mainly in arterioles and lateral muscles. So vasoconstriction is observed in skin, mucous membrane, renal blood vessels. Vasodilation is observed in skeletal muscles, liver, some extent coronary blood vessels. Effect on cerebral blood vessels depends on the blood pressure and change accordingly. Coming to the lungs, it causes bronchodilation due to its beta 2 activity, inhibition of mast cell secretions, and inhibition of histamine secretions. Coming to the gastrointestinal muscles, it causes decrease in peristalsis. Coming to the urinary bladder, it causes inhibition of micturition. And coming to the metabolism, it increases glucose levels. What are the uses of adrenaline? Anaphylactic shock, cardiac arrest. It is used to control local bleeding, and it is also used to prolong the action of local anesthetics. Coming to noradrenaline, many people generally think that adrenaline and noradrenaline have similar actions, but no. As you can see here, adrenaline does not show its activity on beta 2 muscles, beta 2 receptors. As you can see, alpha 1, alpha 2, beta 1, and beta 3 activity, but there is no presence of beta 2 activity. So what are the effects of noradrenaline? Noradrenaline causes increase in blood pressure. It causes bradycardia, whereas adrenaline and isoprenaline produces tachycardia. This bradycardia is mediated by vagus nerve due to rise in arterial pressure stimulates baroreceptors. There is no bronchodilation observed in the case of noradrenaline as there is no beta 2 effect. But noradrenaline do not have persistent effect on heart. Next, coming to isoproterenol. Isoproterenol shows its activity on all beta receptors. So the effect is fall in diastolic pressure due to beta 2 action and rise in systolic blood pressure due to beta 1 action. But the mean action is fall in blood pressure. Isoproterenol has positive inotropic and positive chronotropic effect, so it increases cardiac output. It also causes bronchodilation as it shows its effect on beta 2 receptors. It also inhibits histamine release. Coming to the uses of isoproterenol, it is used in bradycardia, ventricular dysarrhythmia, Stokes-Adams syndrome, but isoproterenol is not preferred for cardiac stimulant activity. Coming to the dopamine shows us activity on D1, D2, all alpha and beta 1 receptors but not in beta 2 receptors. Uses: it produces renal vasodilation when given through IV, increases blood pressure and shock without producing arrhythmias. Coming to the selective drugs. Alpha-1 selective drugs are phenylephrine, midazolam and methoxamine, oxymetazoline and xylometazoline. Phenylephrine, midazolam and methoxamine are used as vasopressors, whereas phenylephrine is also used as nasal decongestant. Oxymetazoline and xylometazoline has alpha-1 activity along with partial alpha-2 stimulating activity. It acts as nasal and bronchial decongestant. Coming to alpha-2 receptor agonists, they are clonidine and aproclonidine. Clonidine is used in hypertension. Aproclonidine is used in glaucoma. You have to note here that aproclonidine has weak alpha-2 activity. Coming to beta-1 agonists. Beta-1 agonist is dobutamine. Dobutamine has two isomers, positive and negative. Plus isomer shows alpha-1 antagonistic activity and beta-1 agonistic activity, and alpha-1 antagonistic activity is 8 to 10 times more than beta-1 activity. While coming to minus negative isomer, alpha-1 agonist activity is shown. Next, coming to prenalterol, it is an inotropic agent. Coming to beta 2 receptor agonists, the drugs are salmeterol, bambuterol, salbutamol, it is also called as albuterol, terbutaline, orsiprenalin, which is also called as metaproterenol, and isoxapurin and retoterin. Salmeterol, bambuterol, albuterol, terbutaline, and orsiprenalin are used as bronchodilators, whereas salbutamol, terbutaline, orsiprenalin, isoxapurin, and retoterin are used as uterine relaxants. Coming to beta 3 receptor agonists, orlistat and mirabican. Mirabican is used to treat overreactive bladder, whereas orlistat is used in obesity treatment. Indirect acting drugs. Indirect acting drugs are tyramine and amphetamine. The mechanism of tyramine and amphetamine is stimulate the release of noradrenaline. Tyramine is also used as an anorectic. As you can see here in the mechanism, it stimulates the release of noradrenaline. And we have another drug, cocaine. Cocaine blocks NET transporter. We also have mixed acting drugs like ephedrine and pseudoephedrine. Ephedrine is used in hypertension, bronchodilation, CNS stimulation. Pseudoephedrine is used in nasal and nasal decongestion. The mechanism of ephedrine and pseudoephedrine is it also promotes the release of noradrenaline, but they can also directly bind to the adrenergic receptors. With this, I am going to end my lecture and thank you for watching patiently. Please subscribe to my channel.